So anesthesia for a penetrating eye injury in a 4-year-old child. So first enumerate the challenges in this case. So the challenges of pediatric anesthesia is there. Emergency nature of the surgery with challenge for a full stomach. Challenges of ophthalmic anesthesia and other injuries and comorbidities which can be compounding here. So you don't expect an isolated penetrating injury. For example, a family traveling in the car and a glass piece coming and getting embedded in the child's eye, and also the child suffering from a fracture. Okay, so like that, comorbidities or other injuries also have to be taken care of. So penetrating injuries may need to be dealt more urgently because of the risk of infection and endophthalmitis. So these are all some of the drugs that can be safely used in pediatric patients. And these are the drugs that are used for vomiting and nausea, because they are also going to raise. Instead of saying you want to lower the intraocular pressure, you must use always that you don't want any raise in intraocular pressure. Okay, so don't say I want to reduce the intraocular pressure. You don't want to raise it beyond the normal value.
Yes, sir.
Now, what are the practical approaches for an eye anesthesia? Assess the indication for emergency anesthesia in discussion with the surgeon. Can surgery be deferred until normal working hours or to allow adequate fasting? That is, most of the time it will not be possible for to happen in penetrating injury, as I told you for the earlier reason. But open globe injuries, the surgeon may agree to wait. Carry out full preoperative assessment, including history and examination. Are there any medical or trauma issues that need addressing first? So more life-threatening injuries have to be addressed first before we think of this ophthalmic problem. And if the patient has a full stomach, a rapid sequence induction should be planned. Laryngeal mask insertion avoids pressure response to laryngoscopy and intubation causing raised intraocular pressure. But in the case of full stomach, you must use only a second generation or third generation laryngeal mask airway and not the normal classic laryngeal mask airway. And second thing is, you must always be very competent to manage a patient with LMA. So if you are not that much competent, or you are in your earlier phases of practice, it is always safer to put in an endotracheal tube, even though it is going to cause some stimulation. You will have a safe airway, especially in the scenario of a full stomach. And maintain with oxygen and air. Avoid nitrous oxide, because nitrous oxide can diffuse and cause an increase in the intraocular pressure, as well as it also an emetic agent can cause more post-op nausea and vomiting. Control ventilation during procedure, aiming for low to normal end-tidal carbon dioxide, which will also help to keep the intraocular pressure low. A slight head-up tilt helps to reduce the intraocular pressure. And at the end of the procedure, patient should be extubated on their side after protective pressures have returned. Severe coughing and straining to be avoided, as this increases the risk of ocular hemorrhage. And patient does not have a full stomach, it is not deemed the risk of aspiration, then you can give general anesthesia after adequate starvation, as you do routinely for an elective patient. Post-operative nausea, vomiting, and pain should be kept to minimum so that it will avoid a rise in intraocular pressure. Regional anesthesia are contraindicated in cases with penetrating injury, as local anesthetic injection in such cases may increase IOP and increase the risk of exclusion of the ocular contents. Okay? So that is the small way of writing out this answer. Okay. Okay. Any questions?